Hello, I'm Carmen Barbas. I'm an associate professor of pulmonary and critical care medicine at the University of São Paulo, Brazil. And it's a pleasure for me to share this AMIB ESICM webinar about what's new in ARDS with my colleagues from Brazil, Marcelo Maia, and Jalila Ben Khalil from Tunisia.
Hello, everyone. My name is Marcelo Maia. I am a past president of the Brazilian Society Critical Care Medicine. For me, it's a pleasure to partnership in AMIB, in ESICM. In the next events for all is important. The RDS for all in two works in ICUs in the world. Thank you, Carmen. Thank you, Jalila. Thank you for all. It's a pleasure to me.
Hello, everyone. I'm Jalila Ben Khalil. I'm a professor in intensive care in Tunisia. I'm head of the Department of Intensive Care on Abdurrahman Hmemi Hospital in Tunis. And I'm president of ATR, the Tunisian Association of Intensive Care. It's a pleasure to me to share with you this meeting on what's new in ARDS. Thank you, Carmen, and thank you, Marcelo, and thank you, everyone.
Hello, everyone. Good morning, good afternoon, good evening, wherever you are. I'm very happy as the president of ESICM, but also as a close friend of many colleagues from Brazil. I feel that I have a family in Brazil with all my good friends. It's an honor for ESICM to welcome this joint session with AMIB. I think it's beyond our friendship to transcend borders. It's also this shared commitment for excellence that we want for intensive care. I want to say that we really admire our colleagues from Brazil. You have an impressive contribution to the field of intensive care medicine, and we do recognize this clinical, human, social, and research endeavor, but we also appreciate a lot our friendship and the way we work together. I want to emphasize that at a human, at a social, at a professional level, we feel very close with our colleagues from Brazil. We recognize that beyond all the geographic boundaries, we have many shared values. We are the same way when when we have to provide compassion, empathy, when we work on specific domains and with the just released guidelines for ARDS on behalf of the European Society of Intensive Care Medicine. This is a unique opportunity to come together and to show to everyone how we have so much respect for each other and how much we want to learn from each other. And this is why we are doing this webinar. So thank you, our colleagues from Brazil. Thank you to Jalila, our colleague from Tunisia, for not only our friendship, but also for this very precious partnership and amazing commitment to excellence. I just say a word. We love you, AMIB.
Yes. So we will start this meeting with Giacomo Grasselli from Milan Polyclinical Hospital, Milan, Italy, and he's going to show us the ESICM ARDS guidelines. Thank you, Giacomo.
Thank you all. Thanks, Carmen, for the introduction. I'm Giacomo Grasselli from Italy. In the next 15 minutes or so, I will try to summarize 2 full years of work. These are my conflicts of interest. So you may know that we started this project almost 2 years ago, thanks to the endorsement of the ESICM leadership. I was honored to be selected as co-chair of the process. And so we decided to investigate these 3 broad areas of investigation. And we decided not to deal with pharmacotherapies excluding neuromuscular blocking agents. So I was appointed as co-chair together with Luigi Camparotta and Caroline Calfi, and we identified 16 international experts from all over the world. And we also involved 8 patient and family member representatives in the process. And we identified 9 domains of investigation. The first 2 are more narrative domains, and the other 6 are more practical, more clinical domains. So this is the picture of showing all the experts that led the 9 domains, but there are many other experts, as I told you, almost 70, who are not pictured here. We had the first 2 domains were more narrative domains, and then we had again 6 clinical domains with 16 PICO questions. We decided to focus only on randomized controlled trials in adults and only in articles in English. What was very important and novel in these guidelines is that we prepared a recommendation for COVID and non-COVID ARDS. Of course, we followed the grade methodologies, and all recommendations underwent anonymous voting, and we adopted a threshold of 80% agreement for adopting or refuting a recommendation. The primary outcome selected was mortality at the longest time point available, and then there were secondary outcomes selected based on the risk of bias of the different studies. So the first domain was the definition domain. It was a narrative domain, and the only thing I want to say is that our aim was not to issue a new definition of ARDS. We only wanted to discuss the good and the bad of the current Berlin definition, and to see if we can expand the access to the definition of ARDS, and also to see if it's reasonable to review the minimum time frame for meeting the criteria for ARDS. But again, it was a discussion of the framework and to open the door to a possible new multi-societal definition of ARDS. The second narrative domain was on phenotyping. You know that it's a very hot topic now. So we tried to address these 3 questions: the definition of a subphenotype, the evidence for a certain heterogeneity of treatment effect between subphenotypes, if there is a relationship between subphenotypes and patient outcomes, and what are the open questions for the future. Then we moved to the more clinical domains. The first one was on nasal high flow. 2 PICO questions. The first one is the comparison between nasal high flow and conventional oxygen in patients with acute hypoxemic respiratory failure of COVID or non-COVID etiology, and we also did a sensitivity analysis on the immunosuppressed patient group. You can see here the forest plot, and the recommendation is a strong recommendation in favor of the use of nasal high flow as compared to conventional oxygen to reduce intubation, while there was not enough statistical power to issue a recommendation for mortality. The second PICO question was the comparison between nasal high flow and NIV. And as you can see from the forest plot, there is basically no difference. So we were unable to make a recommendation for or against the use of nasal high flow compared to CPAP NIV. For the treatment of patients with non-COVID-19 acute hypoxemic respiratory failure to reduce both intubation and mortality. We issued a weak recommendation in favor of nasal high flow in COVID patients to reduce intubation as compared to CPAP NIV. The fourth domain was non-invasive ventilation, and here the PICOs are mirroring the ones that we were using for nasal high flow. So the first one is the comparison between CPAP NIV and conventional oxygen. The primary analysis that you can see there was focused only on the studies with low risk of bias, and in those studies we were unable to find the difference in favor or against the use of CPAP NIV as compared to conventional oxygen for patients with non-COVID acute hypoxemic respiratory failure. But again, a weak recommendation in favor of NIV CPAP as compared to conventional oxygen to reduce intubation, but not mortality in patients with COVID-19. The second question was a comparison between helmet and face mask. As you all know, there is only one study making this direct comparison. It's a study by Patel, published in JAMA. We judged that it was a single center, too small study, so we found it not enough strong to give us the power to issue a recommendation in favor of the helmet as compared to CPAP. And there are no data on the direct comparison between NIV and CPAP. The fifth domain was low tidal volume. This gave us a lot of discussion, because as you can see from the forest plot, the diamond crosses the identity line. So technically speaking, from the strictly statistical point of view, there is no significant difference between low and high tidal volume. We defined low tidal volume 4 to 8 ml per kilos of predicted body weight as compared to larger tidal volume used traditionally to normalize blood gas. We felt very uncomfortable with this. So in the end, what we decided to do, it's a bit, democratic, but I mean, what we decided to do was to issue a strong recommendation in favor of low tidal volume. But as you can see here, it was a strong recommendation based on expert opinion, because we felt that the physiological background was too strong. And so our feeling is that we all want to recommend low tidal volume despite the lack of statistical significance. Then we delve into these PEEP recruitment maneuver domains. There are 3 studies comparing low versus high PEEP strategies. And as you can see from the forest plot, there was no difference between these 3 studies. And so we were unable to make a recommendation for or against routine PEEP titration with a higher PEEP FiO2 strategy versus a lower PEEP FiO2 strategies, both in COVID and non-COVID ARDS. We also, sorry, this advances too fast. We also meta-analyzed the studies exploring PEEP titration guided by respiratory mechanics. So we included the 2 studies on esophageal pressure, but we also included the ARDS trial in this. And again, we found no difference. And so we were unable to make a recommendation for or against PEEP titration guided by respiratory mechanics as compared to a PEEP FiO2 strategy. Then we tried to assess the effect of recruitment maneuver. As you all know, it's quite difficult, because it's difficult in the trials to define the effect of recruitment maneuver independently from the effect of the PEEP strategy you adopt. But we decided to define high pressure recruitment maneuver as defined by airway pressure more than 35 centimeters of water for at least 1 minute. And in this case, we had a strong recommendation against the use of high pressure recruitment maneuvers. This was mostly based on the effect of harm shown in the trial. While we also tried to see if there is an effect of brief high pressure recruitment maneuver. So again, more than 35 centimeters of water for less than 1 minute to reduce mortality in patients with ARDS. And in this case, we only had a suggestion against the routine use of brief recruitment maneuvers. Then the 7th domain is prone positioning, and we decided to focus mostly on the results of the PROSEVA trial by Claude Guérin, published in the New England Journal of Medicine. And based on the PROSEVA trial, we were all concordant on the issuing of a strong recommendation in favor of prone positioning, in favor of the use of prone positioning according to the criteria of the PROSEVA trial. So in patients with moderate to severe ARDS with PF ratio below 150 and at least 5 centimeters of water of PEEP after a period of optimization of ventilation. And this is also applies to COVID-19 with a reduced level of evidence for indirectness. The second bigger question is when we decided to start from positioning. And again, we said that we want to start from positioning in all patients with ARDS with a PF ratio below 150, and prone positioning session should be prolonged at least 16 hours per day. And this is very important. We also recommended that prone positioning should continue even if there is no improvement in oxygenation during the proning session. We also decided to explore awake prone positioning. You know that awake prone positioning was very popular during COVID. And indeed, there is no evidence in non-COVID ARDS, while for COVID ARDS, we had a suggestion in favor of awake prone positioning to reduce intubation, but no evidence of a reduced mortality. Neuromuscular blocking agents, as you all know, there are two large randomized controlled trials published in the New England Journal of Medicine, the study by Papazian, the Accursis trial, and the ROSE trial. And as you can see there is no statistical difference. So we decided to give a recommendation against the routine use of continuous infusion of neuromuscular blocking agents. I want to warn you, we are not completely against the use of neuromuscular blocking agents. We recognize that in some patients it's impossible to ventilate them without neuromuscular blockade. The only thing is that we should not apply in every patient with ARDS. And finally, we have the ECMO extracorporeal CO2 removal domain. For ECMO, we meta-analyzed the CESAR trial and the EOLIA trial, and we finally had a strong recommendation in favor of the use of ECMO as the rescue treatment for refractory hypoxemia, as defined with the criteria adopted in the EOLIA trial. Of course, ECMO should be applied in experienced centers with a very standardized method of management of the patient, while for extracorporeal CO2 removal, mostly based on the results of the REST trial, we decided to give a recommendation against the use of extracorporeal CO2 removal in patients with ARDS, not due to COVID-19, outside of randomized controlled trials. And so this is the final slide that compares the previous recommendation of 2017 guidelines and the current recommendations. And I invite you to read the paper that has been published in Intensive Care Medicine. And with this, I thank you all for your attention.
Thank you, Giacomo. Next presentation, Professor Marcelo Amato. Marcelo Amato from Brazil, University of São Paulo. And a professor with expertise in mechanical ventilation in Brazil. You have 50 minutes to explain to what to avoid in ARDS. Marcelo Amato, please.
Morning or good afternoon to everybody, and I'm very grateful to ESICM and AMIB for this meeting, and it's a pleasure to be here. What to avoid in ARDS? My presentation is going to be a little bit different from Grasselli, especially because this title is very broad, and I tried to emphasize much more a physiological approach. So these are some topics that I elected, and I'm going to address a few of them, especially the first three: wasted minute ventilation, futile driving pressure, and ignoring muscle pressure. All of these is based on physiological background, and we have lots of clinical data on this, and I decided that this was extremely important to convey. What I call wasted minute ventilation. So this is a statement from a resident of mine opened my mind. Is it true that in an adult ARDS patient, if he is presenting a PCO2 of 35, we should say that he is receiving bad treatment or any value below 45? Is this statement always true, or we should let's say, consider it in relative terms? My proposal is that this is always true, and let me try to convince you. First of all, using the data bank of almost 5,000 patients, we tested how much hypercapnia is related to outcomes. And this is the univariate analysis. It's a U-shaped curve. Okay, so lower mortality in intermediate values, higher mortality if you have alkalosis, respiratory alkalosis, and higher mortality with permissive hypercapnia. But what happened when we do multivariate analysis is this. So hypercapnia, the highest quintile of hypercapnia was protective. And very consistently, alkalosis, respiratory alkalosis was dangerous, very dangerous. Hazard ratio, so 30% increase in mortality when we adjust for all the parameters. Very consistent results. And we have to consider that we have more than almost 500 patients with pH levels below 7.25. Okay, so it's a big number of patients with good prognosis because they were receiving hypercapnia. And it's not only this. If you go to the lung safe study, look at this conclusion. Of concern, mortality was higher with hypocapnia. So PCO2 levels below 45 were associated with higher mortality. Why this? There are two main reasons. One is that alkalosis is bad per se, and the second one is that you are wasting minute ventilation, so you are causing ventilator-induced lung injury without any need. Then you could think about problems in the brain, but I can tell you that in the brain, very interesting studies, physiological studies showing that intermediate values of hypercapnia are better for the brain, for brain hypoxia, and also for subarachnoid hemorrhage. But as you can see, if you have hypocapnia, this is very, very bad for the brain and also for the lung. So in this case, subarachnoid hemorrhage and specifically PCO2 levels less than 45 increases hypoxic ischemic brain damage, and mild hypercapnia was good. And in this very interesting publication in the lung safe derived from the lung safe study, one of the largest cohorts on mechanical ventilation, you have to understand that the average PaCO2 was 45. What does it mean? That half of the population had PCO2 levels below 45, and we have very good evidence that this is deleterious, or at least you are wasting minute ventilation, you are wasting respiratory rate, or you are wasting driving pressure, and all of these, they are well proven to be factors, modifiable factors that can improve outcomes. So I see no excuse to have a patient with ARDS with low PCO2 levels. Futile driving pressure. So this is the result of our study showing that high driving pressure increases mortality by 2 times if you are at this range above 20 of driving pressure. It's interesting because driving pressure has an interesting story here in Brazil because our ex-future president had ARDS, and in the last year, the results of his autopsy were published, and he received driving pressures of 50 centimeters of water. And this is his lung weighing 2.5 kilos, with lots of traction bronchiectasis. So the history of Brazil was very dramatic about this and the consequences of having a futile driving pressure. And also during the COVID time, we could see that patients that were not receiving protective ventilation according to minimum standards, so patients receiving high driving pressures, plateau pressures above 30 or tidal volumes above 8 mL per kilogram, they had a worse prognosis. And this is in our hospital, a university hospital. So still today, lots of room for improvement. Also, driving pressure is related to fibrosis, and this is an interesting study of follow-up of patients with ARDS. So driving pressure was related to pro-collagen production and lung fibrosis. Patients with high driving pressure had increased pro-collagen in the lung and in the blood at the very beginning of ARDS, and they increased along the week. In contrast, those patients with low driving pressure, they didn't present such an increase. Interesting enough, we have now different sources and different studies showing the same results in different cohorts. This is a paper published in Intensive Care showing that in COVID patients, high driving pressure were related to sequela. Sequela means low vital capacity, low carbon dioxide diffusion. So these patients had more lung fibrosis and sequela if you are using high driving pressure during mechanical ventilation. Much more than, so driving pressure was related to this, but not precisely, not directly tidal volume. And more interesting is that in different, let's say, fields in pulmonary medicine, patients with lung fibrosis. You see here a patient with interstitial lung disease and diaphragmatic paralysis. You can see that lung fibrosis is much more prominent in the side of the lung in which the diaphragm is working. So this suggests that the own effort of the patient is causing lung fibrosis. Another study showing that after cardiac arrest, driving pressure is extremely important. In pulmonary edema, high driving pressure has increased probability of death in pediatric patients, so the evidence are amounting. And especially, I would like to call attention to this recent publication in Critical Care with almost 100,000 patients. And this paper was very interesting for the following reason. They matched the patients according to compliance. So it's a case control study in which patients were matched to very similar lung compliance, trying to isolate severity of lung disease from driving pressure, which means that we are comparing here patients with precisely the same compliance at baseline and checking if driving pressure is increasing mortality. And this is patients under general anesthesia. And interesting enough, tidal volume was not related to mortality. But look at this. This is tidal volume in those patients. And you can see that there are two clusters of patients. So some patients receive tidal volumes around 9 mL per kilogram and until 11 mL per kilogram, patients under general anesthesia. And some other patients they received 6 to 8 mL per kilogram. Why? Look at the x-axis, individual anesthesiologist. Each number here is one anesthesiologist. So a different anesthesiologist was responsible for the patient. Instead of receiving 7 mL per kilogram, he received 9 mL per kilogram. And these patients were matched for compliance. So same compliance, but receiving a slightly higher tidal volume. What happened? Mortality increased 45% because driving pressure increased by 8 centimeters of water. So for the same compliance, same severity of lung disease, just a sloppy protective ventilation strategy caused increased mortality. Which is the threshold for driving pressure nowadays, we believe, and from multiple sources from thousands of patients, suggest that even 15 is not enough, and we should try as much as we can driving pressures below 12 centimeters of water. And my last topic here is the ignorance about muscle pressure. We discussed a little bit about this evidence of pulmonary fibrosis being enhanced by strong muscle contraction. But I would like just to call attention to some recent evidence about strong efforts causing damage to the lung. First of all, there was a big discussion if your muscle effort can cause lung damage. I think that this should never be discussed, because there is a strong evidence, for instance, from marathon runners that they have beelines after running a marathon with pulmonary edema. And lots of experimental studies are showing inflammation if you have strong efforts. For the same tidal volume, a higher diaphragmatic effort causes more inflammation. And very recently, we have shown that a strategy in which you try to avoid a very high sum of ventilator driving pressure plus muscle driving pressure can improve the pulmonary function. For instance, if you have a patient with medium effort and high pressure control, pressure support ventilation, if in this patient we tried to reduce a little bit the ventilator pressures, and in this way we tried to protect a little bit more the patients. This improved the outcome, the pulmonary outcome of these patients. And likewise, if the patient had a big effort and low support from the ventilator, so the problem here is the driving pressure is much more caused by the muscle effort. In this case, we increase sedation or we perform the partial paralysis. And by doing this, we could increase what we call time to oxygen free. So which means that these patients needed supplemental oxygen much less than the control group. A median time decrease in the time required, time in which you required oxygen, a big decrease like 8 to 10 days. So these are, I think this is my last slide. There are many topics that we could address in terms of simple attitudes that you could have at the bedside, but I decided to focus on these neglected problems. Futile driving pressure, futile minute ventilation, and high muscle pressure, which means that you should pay attention to a patient doing strong efforts. Thank you very much.
Thank you, Marcelo. And the next talk is about surviving ARDS, and will be presented by Lise Piquilloud from Lausanne, Switzerland. Please, Lise.
Good afternoon or good morning. It's a pleasure to be here today. I'm going to show you what we know about the long-term outcome of our patients who had ARDS. And in the end, I'm going to discuss maybe what we could do to try to improve these outcomes. Then, first of all, as we all know, mortality in ARDS is very high. When the syndrome was first described in 1967, mortality was around 70%. Then this mortality progressively decreased. Why did this mortality decrease? Probably because since the middle of the 80s, we were aware that we can cause ventilator-induced lung injury when we deliver high tidal volumes and or high pressures. And this led to a major change in the treatment of those patients, because we didn't try to correct blood gas analysis anymore, but we tried to deliver more gentle ventilation, what we today call protective ventilation, meaning not too high tidal volumes, low pressures, and enough PEEP. Of course, enough PEEP means enough PEEP to recruit, but also not too much PEEP to avoid overdistension. Then we can say at this point that the progressive decrease in ARDS mortality during the past 40 years is probably related to the widespread of protective ventilation. At this point, it's important to discuss some important ideas regarding the epidemiology of ARDS. I would like to shortly describe some of the results of the LungSafe study, which was a big observational study that was conducted with ESICM, and more than 13,000 of patients with ventilatory support were included in this study. They came from 50 countries from all over the world and nearly 500 ICUs. And what is important to note here is that ARDS is a frequent syndrome. About 10% of the patients who were admitted in one of the participating ICU fulfilled the Berlin criteria for ARDS. And mainly those patients had moderate ARDS, which means that at time of diagnosis, they had a PF ratio between 100 and 200 millimeter of mercury. And maybe even more importantly, if we only look at the patients who were invasively ventilated, nearly 25% of them had the criteria for ARDS. And what is also very important in this study is that we all know that protective ventilation is good. But basically, as said by Marcelo before, we still have room for improvement. Because as you can see here, all the patients who were outside the red square were ventilated with more than 8 milliliter by kilo of tidal volume and or more than 30 centimeter of water of plateau pressure, which is not what is recommended for an ARDS patient. What about mortality in this big observational study? Then overall mortality in ARDS patients was 40%. And of course, the most severe the disease, the higher the mortality. And the mortality range from 34.3% in mild ARDS to 46.1% in severe ARDS. And we know that very well. If we have a very severe hypoxemia, then the short-term outcome, at least, is bad. Then we also have those data that are very recent, published online earlier this month. And the group of Patel put together a lot of ARDS patients. They put different databases together, essentially databases from clinical trials on different treatment strategies, but also a big observational cohort that was not the LungSafe cohort, but another one. And again, they found that mortality in ARDS remains high, around 40%, as we know. And they also showed that the age at time of ARDS is important regarding the 90-day mortality. And as expected, if the patient is older, the mortality is higher. Then this is about mortality. But now we also have the other side of the coin, and we have ARDS survivors. And for those survivors, there are a lot of open questions. Then what are the respiratory sequelae of those patients? What is the functional recovery of those patients and the functional capacity, the long-term after ARDS? What is the psychological impact of having an ARDS and of having been ventilated often during a prolonged period of time? And finally, what is the quality of life of those patients we have treated for an ARDS? Then, regarding the respiratory sequelae, these are already old data, but that are very important, published by Margaret Erridge. And she showed that after 12 months, basically, the lung functions were not so bad. Forced vital capacity and total lung capacity were nearly normal in a cohort of ARDS survivors. However, as also said previously by Marcelo, we still had abnormal carbon monoxide diffusion capacity. Then the lungs did not totally recover. And if we looked at a longer period of time, we can see that after 5 years, we still not have a normal carbon monoxide diffusion capacity in the patients who survived ARDS. Then we can say that overall, the lung function tests are quite good late after an ARDS, but diffusion capacity remains altered. We have also new data regarding ARDS based on different cohorts of COVID-19 ARDS. This is one of them, the one from Switzerland. And in this study, we included 113 COVID-19 survivors, and 2/3 of them had ARDS. And after 4 months, we found nearly the same thing as Margaret reached a longer time ago. Total lung capacity and forced vital capacity were nearly normal, but carbon monoxide diffusion capacity remained low. And this was still the case after 12 months in the same patients. And overall, in 80% of the patients, the DLCO was lower than 80% of the predicted value in 68% of the patients, which is a lot. And of course, if we look at the CT scan, we can see that after 4 months, we still have important abnormalities on the lung parenchyma that are still signs of fibrosis. And the most severe the ARDS was in the acute phase, the worse the images were. Now, what about other consequences of ARDS? Here we have a picture of a 46-year woman 3 months after severe ARDS due to community-acquired pneumonia. And we see that she experienced a huge weight loss and huge muscle wasting. And after 3 months, she was still unable to abduct the arm. And from a more general point of view, you have here the weight that was lost by ARDS patients, nearly 20% compared to baseline weight at hospital discharge. And even after 12 months, the survivors of ARDS did not regain their initial weight. Then there is a major weight and muscle mass loss after ARDS. Then what about the functional recovery of those patients? Then first of all, at 5 years in the age cohort, 20% of the patients who initially survived had died. And among the 80% who were still alive, you can see that the exercise capacity was still markedly reduced. And at the 6-minute walk test, basically, patients who experienced ARDS only had about 62.5% of the predicted value for the 6-minute walk test. Then a huge functional disability. And what about returning to work? Overall, after 12 months, only 49% of the patients were able to return to work. And after 5 years, as you can see here, only 77% of those patients return to work. Those who return to work usually were able to return to the original work, which could be considered as a good news. But definitely, there are a lot of late sequelae that prevent returning to a previous life and previous quality of life. Now, what about the neuropsychological sequelae? As you can see here, between 1 and 6 years after ARDS, there are a lot of cognitive disorders that are reported in ARDS survivors. About 25% of the patients have cognitive disorders. And there are also a lot of post-traumatic stress disorders, of anxiety, panic attacks, nightmares, and also depression. Then there are a lot of neuropsychological sequelae overall. And here we have the quality of life of ARDS survivors as published by Margaret Herridge already a long time ago. And you can see that compared to what is expected for a normal population, the quality of life scores for mental health were lower, and the physiological quality of life score were also lower than a normal population and were even more impaired compared to the mental status score. Then there is definitely an impact on the quality of life after ARDS. And we also have some new data about this. This is a cohort that was published last year by a German group, and they followed nearly 900 ARDS survivors. Age of these patients was around 50 years old, and they stayed during 23 days in the ICUs. And they were followed up to 36 months after ICU discharge, and they filled a self-reported questionnaire. Then what can we see in this cohort? Then overall, after 3 years, only 57% of patients returned to work, and a lot of these patients had neuropsychological sequelae, as already shown by Margaret in another patient group, and about 10% of the patients suffered from panic disorder and or from major depression, and a huge amount of patients, 1/3 of them, were considered as at high risk of having a post-traumatic stress disorder. Regarding quality of life, we find also the same thing that was shown by Margaret Herridge in the past. Regarding the mental component of the quality of life score, the values were lower than the average in a population who did not suffer ARDS. And same thing for the physiological component of the quality of life score. And again, the physiological component was even more altered compared to the mental component. Then in summary, ARDS mortality has decreased over time, but remains high. ARDS survivors have no major pulmonary sequelae except altered diffusion capacity of carbon monoxide. ARDS survivors have limited exercise capacity, even after a long period of time, which was 5 years in the study, frequently have neuropsychological disorders, have reduced quality of life, and overall, only between 75 and 70% of ARDS survivors return to work after 3 years. Can we do something to improve quality of life? Maybe yes, as demonstrated by the group of Alex Demoule in France, published 2 years ago. There is a correlation between dyspnea in ventilated patients and post-traumatic stress disorder. And as published also by the same group, we can decrease dyspnea simply by optimizing the ventilator settings and also by using opioids. Then we could imagine that if we were able to treat dyspnea correctly, we could have an impact, at least on the neuropsychological sequelae of our ARDS patients. Then let's try. Thanks for your attention.
Thank you, Lise. So you have 6 minutes for the discussion section, and the audience have some questions for us. And the first one is how to adjust driving pressure to avoid futility. Marcelo.
Thanks, Carmen. Thanks for the question. I think the idea, first I would should be a stepwise approach. First of all, you have to start with reasonable levels. I think from the, let's say, cumulative evidence, we should aim something below 12 centimeters of water. Between 12 and 15, you have to be already in a yellow zone, so you should not be completely, let's say, completely relaxed. And finally, we know now that the respiratory rate is also very important. And then to combine both, a good strategy is to look at your PCO2. And then if you're having a low PCO2, we are wasting ventilation, we are wasting driving pressure and respiratory rate. So this is why I believe that a PCO2 less than 45 is an indication of bad treatment of ARDS.
Jalila, can you read the next question for our audience, please?
Yes. The question is, why was the guideline not a joint guideline with ATS? Because there are differences in between. Someone will respond to this question?
This is a polemic question. It's why was the guideline not a joint guideline with ATS? Because there are differences in between. Can the speakers answer this polemic question?
This is a very important question, and as you know, at an ESICM level, we are very close to our colleagues from everywhere, including from those from the US and from the ATS. The idea to promote guidelines is also based on the willingness of a group that is the acute respiratory failure group from the ESICM to promote guidelines. So there are guidelines on ARDS, there are guidelines on other domains that are mostly led by the sections. So ESICM sections have actually included colleagues from Europe and from all over the world. So we are not, only, we are in Europe, we are the European Society, but we have members from much beyond than Europe. So the people in the section included the different members of the ARF section, and this is how the guidelines were made. So ATS and ESICM should be seen as complementary guidelines. We don't think that we oppose to each other. There are different views, and it is interesting to learn from these different views. And maybe we should promote a webinar on looking why these different views translate actually into different patients' outcomes. If I may, I would like to take the opportunity to ask something to Marcelo and something to Lise. And first to Lise on when we are at the bedside and we are having a severe ARDS patient. So you report on many risk factors for long-term cognitive outcomes and for long-term cognitive dysfunction. And of course, the ability and the hope of every ICU specialist is to restore life with a good quality of life. So what are your recommendations when we are at the bedside of a very hypoxemic and a very sick ARDS patient? What should we do to think on a year later?
Then there is one thing we know is that we should deliver as far as possible protective ventilation, because as we said, the physiological rationale to think that this can impact on the long-term outcome is very strong. And in addition, we observed in parallel the decrease in mortality and the implementation of protective ventilation. Then that we should do. And then we probably should try to avoid what can promote anxiety, nightmares, and post-traumatic stress disorders. And for that, dyspnea is maybe something, pain is for sure something. And we could also imagine a lot of other interventions, also related to the participation of the family in the care, of opening our units, of improving the communication with the family and when possible with the patient, because we also have quite strong arguments to think that this could change the long-term outcome. It's, however, very difficult to demonstrate, because if we implement now in all our units all those different aspects, we need 5 or 10 years to know whether it works or not. But as for physiology, the rationale is strong. Then we should also try to improve the holistic care of our patients.
Thank you very much, Lise. And certainly the sedation practice are also very much associated with long-term outcomes, and we should either follow the guidelines or maybe take very much attention to that. Marcelo, I have a question for you. Like Lise and you, we are fully admirative of everything you do. Lise is driving the ARF section wonderfully, and you are, you know, a leader of the physiology. And I think it's very important that you can tell us a very clear explanation. Physiology has really driven the way we are delivering mechanical ventilation to our patients. We have learned from that. We know that it is the basis of it. And we also know that from these basics, we need to move and understand. And now, my question to you is, how can you explain the disconnect that we see sometimes on the physiological evidence that cannot be discussed and sometimes the negativity of some trials, or sometimes even some results might be counterintuitive, and you have been among the first to have shown that. So you are both a clinician and also the one of the top respected physiologists in the world. So my question to you is, and mostly for the young generation, how can we reconnect that and how can we understand the results to deliver more physiological-based mechanical ventilation at the bedside?
Thank you, Eli, for this excellent question. And I think the main reason is because we don't have a good monitoring system. And let me at the bedside, and it's completely different from the physiology lab. And let me give you an example. Because we were at the very beginning of protective ventilation, I remember very well that it took us 10 years to understand that we should reduce a little bit tidal volume. And then everyone that was at the bedside was telling me, oh, I have been doing mechanical ventilation for years. And if 12 mL of kilogram of tidal volume was doing bad for the patient, I would know. And physicians don't know because the damage is going to happen in the next shift, in the next week. And then physicians cannot relate at the bedside. So then some problems, they look simple at the animal lab, but they are complex at the bedside. One of them, for instance, is tidal volume. You try to reduce in patients, and then you have breath stacking. In the same way, you try to increase PEEP, and then the patient starts to fight using abdominal contraction. So if we now we are improving our understanding and our monitoring, and I believe in the next years we will have much richer results in terms of outcome, because we have to understand that the principle, the physiological principles are still there, but at the bedside, the complexity is very huge, and we need much better monitoring. One last word is, I think one of the enemies of a protective strategy is the skepticism. And for instance, in my country, in my society, I see many physicians saying that everything that should be done for protective ventilation is already done. And look at the presentation of Lise. the amount of sequela is huge, and we know that sequela is correlated to the ventilator settings. And I showed in COVID that protective ventilation was not applied in a big proportion of patients. So one of the enemies is skepticism. And then the second one is a lack of monitoring.
Thank you so much, Marcelo. Thank you very much, Lise, and thank you to Giacomo. I think that this webinar, in addition to show how much we are connected to our colleagues from Brazil and from Tunisia, Jalila is here with us, is also showing that thinking together on the best way to deliver care at the bedside, but also to think on longer-term outcomes, can really make a change for our patients. This was a webinar on ARDS. Carmen, we were very happy. Marcelo, we were very happy to do that with AMIB, and we had wonderful speakers. Again, thank you for this collaboration. And I would like to, for every one of you, to hope for you the best possible day, and to see you very soon on ESICM. I would say the ESICM Netflix, which is our academy, where you can see a lot of those webinars, a lot of courses, and a lot of training. Have a great day, and thank you again, everyone.